Hello and welcome to another e-learning video offered to you by the Synapse. Today we'll be discussing male sexual dysfunction and, more importantly, erectile dysfunction. And with us today we have Mr. Andrew Mercieca, a urologist, who will be speaking to us about the management of these conditions and also how they can serve as indicators to other medical problems. Thank you for accepting our invitation today.
It's my pleasure.
And joining us. Our first question today will be about male sexual dysfunction. How common is it and what can you tell us about it?
Yes, when classifying sexual dysfunction in both males and females, one has to take into consideration that it is a multifactorial problem. Really, sexual dysfunction, rather than a pathology in itself, is a symptom. It is a symptom of other diseases or other pathologies which may be more serious than the sexual dysfunction itself. I would classify sexual dysfunction into psychological or organic. And in males, specifically in males, the most important sexual dysfunctions are erectile dysfunction and premature ejaculation. Psychological problems include anxiety, couple issues, gender issues, psychiatric and psychological issues which do compound the problem itself. In most cases, the issue is combined, a mixed etiology. So, and I would say it is really a vicious circle. When there is an organic problem causing, let's say, erectile dysfunction, this is easily compounded by psychological problems. Before going into the incidence and prevalence of the problem of erectile dysfunction, which we will be discussing today, I would like to define it. What is erectile dysfunction? I usually use the National Institute of Health definition that was published in the journal of the JAMA in 1993. And erectile dysfunction is defined as the persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. So this is linked really to the quality of life, and to the quality of life not only of the male, but also of his partner. Erectile dysfunction is common, perhaps commoner than we think. And the first major study to study the prevalence and incidence of erectile dysfunction is the Massachusetts Male Aging Study. And the report was published in 1994, and it shows that the overall prevalence of erectile dysfunction can be as high as 50% in males of the age group between 40 and 70. So it is a common problem. In Europe, the Cologne study, published in the year 2000, shows that the prevalence is around 20% in a wider age group of between 30 to 80 years of age. Some studies even go on to say that 25% of males that present with erectile dysfunction do so in the age group which is younger than 40 years of age. So basically, erectile dysfunction is a common problem. Rather than a disease, it is in fact a symptom of other problems.
And in fact, today we're planning to focus mainly on erectile dysfunction.
Yes.
How would you investigate such a condition, and what can it tell you about the medical state of the patient?
I would go on and ask another question. Why should we investigate it, in fact? And the real reason why we should investigate a symptom is because of the risk factors that it shares with cardiovascular disease and diabetes. So basically, we do not want to miss the boat. So males, especially middle-aged males that share risk factors with cardiovascular disease should be investigated not only to better the couple issue or the quality of life, but also to minimize the risks of severe ischemic problems. And obviously, erectile dysfunction may be the presenting symptom of diabetes, ischemic heart disease, peripheral vascular disease, hypogonadism, neuropathic disorders. And I would investigate my patient, first of all. The most important thing, as usual, is history taking. And it is the couple of minutes listening to the patient does give you an insight of the problem itself. So, first of all, I really encourage the setting up of a specialist clinic. I always stress that erectile dysfunction, which is a very difficult subject to discuss with anybody. There's always an element of embarrassment, an element of sometimes doubt in the partner. That should be discussed and managed in a specialist clinic, and ideally in the presence of the partner, although should not always be in every visit. Okay. The second thing is in the history taking is to confirm that the problem is in fact erectile dysfunction, rather than premature ejaculation or a problem of desire or a problem of decreased libido, because all these are separate issues. So it is very important to know that the real problem is in fact erectile dysfunction. One should also ask on the onset, was it a gradual decrease in the erection, or was it something sudden? Was there a specific scenario where erection suddenly became weaker? And another important thing is the presence of nocturnal or early morning erections, because that is an indication that there is a good physiological response. Is it a situational issue, or is it always there? What is the severity? How do we measure severity, in fact? Has a new treatment been started by the patient himself, or by his general practitioner or other doctor? What is his current medical history? What is his surgical history? What are the couple's expectations of the visit? So all these are very important at the initial visit of the patient. One of the things to assess the severity is in fact the International Index of Erectile Function, the IIEF. This could easily be done in a very short time because we have the abridged version, which is the IIEF-5. And this is important because it not only assesses all the sexual function domains, but it also assesses the impact of treatment over the last 6 months. So it is a standardized way how to ask questions, and we can in fact have a look at the IIEF, and that will give us an objective assessment of the severity of the erectile dysfunction. Let's say an index value of 1 to 7 will show us that the male is in fact suffering from severe erectile dysfunction, while an index between 17 and 20 will show us that the male is in fact suffering from mild erectile dysfunction. I would suggest a minimal, and in fact it's not I that I suggested, it is the European Association of Urology guidelines on erectile function, which have just been published. They do focus on minimal investigations, which include blood investigations, which will look at the fasting glucose, the urinalysis, the serum testosterone, perhaps a PSA in middle-aged males after adequate counseling of the patient, a full hormone profile that might include a thyroid function test, serum prolactin. But the most important thing is to investigate and stratify the risk of cardiovascular disease. Physical investigation is important, although limited, one must admit, and it should not only focus on the genital area, but also on the vascular examination and the thyroid status.
Mr. Mercieca, earlier on you mentioned that PD5 inhibitors are relatively safe. How safe are they, and how do you tailor them for your own particular patient?
Gabriel, it all depends on the patient that you have. This is safe treatment we're talking about. And it depends on the counseling of the patients and the past medical history, and also on the expectations of the patient. The main concern when taking PD5 inhibitors, and I always suggest that they are prescription medication, is the cardiac risk. And the EAU guidelines suggests that we stratify our patients into 3 risk groups according to the 23rd Princeton consensus. And the 3 risk groups are the low risk category, the intermediate, and the high risk. The high risk group are absolutely contraindicated. The PD5 inhibitors in the high risk group are contraindicated. The low risk category, one may go on and prescribe PD5 inhibitors safely. The intermediate risk group is that group that should be referred to the cardiologist for re-stratification into the lower risk category or to the high risk category. And the high risk category should be, rather than having issues with sexual dysfunction only, they should be referred for revascularization because they're at imminent risk of an acute coronary event or an acute vascular event. I would take a few minutes, as I said earlier, during history taking, I would take a few further minutes to counsel the patients on how to use them, because the main problem with them when they are not effective is that the patient might not have been counseled well. So it is very important to rule out, first of all, the contraindications, which are mainly the high cardiac risk, recent coronary event, and concomitant treatment with nitrates. That is an absolute no-no. And then one should choose the treatment depending on what the patient wants. So one has to ask about the importance of spontaneity, about the importance of whether the patient wants daily dosing, whether the patient has unplanned sexual intercourse or planned, whether the patient is in a long-term relationship or not. The side effects, one has to discuss the side effects, okay, because there are some bothersome rather than dangerous side effects. And one should teach, the doctor should teach the patient how to take them. That ideally the PDE5 inhibitor should be taken on an empty stomach around 1 hour before sexual intercourse. And the importance to stress, the importance that for them to work, sexual stimulation is imperative. It is very important when talking about sexual dysfunction to talk in a relaxed environment and in layman's term.
And that brings you back to the fact that you need to be in a specialist clinic.
Definitely. So basically, the PDE5 inhibitors are safe when given to the right patient.
And what can you comment about the newest development in PDE5 inhibitors, avanafil and...
Avanafil is the latest addition to the other three. We have 4 right now, which are vardenafil, sildenafil, tadalafil, and avanafil. Avanafil, and in fact this was added even to the EAU guidelines, the last edition of 2015, is the latest PDE5 inhibitor. It is the most selective and the least of the 4 PDE5 inhibitors that give side effects due to its selectivity. All could be ideal for certain categories of patients, depending on, as I said, the half-life, on the spontaneity that the patient wants. And avanafil is the treatment with the least side effects.
Thank you, Mr. Mercieca, for your time and for your patience.
It has been my pleasure.
It has been ours as well. And we hope that this video has taught you and helped you understand more erectile dysfunction and its management. We'll be bringing you more information, more content on the go. We hope that you share this video with your professional colleagues, and thank you for following us.